That's fine, sir.
Okay, that is fine. So we'll start because we have about 6 things we want to quickly touch on, so that we'll allow time for questions or clarifications. Okay, so thank you for coming online. We'll be talking about 1, post-date pregnancy, 2, induction of labor, 3, augmentation of labor, 4, a failed induction, indications for Caesarean section, and postpartum blues. Okay, the postpartum blues, will take it under postpartum mood disorders. So straight up to post-date pregnancy. I will just touch on very few things so that we'll allow time for questions and answers, and I will not belabor you with too much technical stuff. The most important thing is to pick the 1 or 2 salient points in these 6 discussions, because each of these topic can go for up to an hour, but we'll try to do justice to it in about 5 to 7 minutes each, such that we'll just dwell on the most important points. Okay, post-date. We all know what a date pregnancy is. When you come to the clinic and they ask you your last menstrual period, it's only to allow the doctor determine when your expected date of delivery is, which everybody knows as your due date. And that is 40 weeks from your last menstrual period. So that is your due date. So anything beyond 40 weeks is called a post-date. A post-date must not be confused with a postpartum pregnancy. A post-date must not be confused with a postpartum pregnancy, because I've told you already that date or your due date is 40 weeks. Why? Postpartum is what? More than 42 weeks. And more often than not, we never allow a pregnancy to get up to 42 weeks before we do intervene. Okay, to give more information, many patients do ask me, doctor, what is term? Because they are reading somewhere there is something called early term, late term, post term, and full term. We do know that a pregnancy is said to be term. Term in quotes means the baby is ripe to be delivered. Meaning that the baby is delivered and there should not be any problem. A term pregnancy is a pregnancy from 37 completed weeks up to 42 weeks. So 37 to 42. So if for whatever reason your baby comes at 37 weeks or 37 weeks plus 1 day plus 2 days plus 3 days, your baby is still term. However, we call that an early term. That is, babies 37 weeks and above are called early term. While a full-term baby is from 39 weeks. A full-term baby is from 39 weeks. While a late-term baby is from 41 weeks. So 37, 39, 41, just 2 weeks in between an early term, a full term, and a late term. And the last is a post-term baby. And we've already said those are babies above 42 weeks. So those are the further subdivisions of term babies. Okay, but just know that once your baby is 37 weeks, your baby is ripe, your baby is good, your baby is okay to come out. And a baby that is past its due date, that is post-date, is not essentially a problem. The problem arises when your baby is post-term. And that is because with a post-term pregnancy, that is a pregnancy beyond 42 weeks, there are many problems that could happen to the baby. One of those problems could be that the baby starts to grow bigger and bigger. And as the baby grows bigger, it becomes macrosomic, that is a big baby. A macrosomic baby or a big baby is a baby above 4 kg. And with a big baby, there's more risk of cesarean section Or if you manage to deliver the baby per vagina, there's more risk of tears and tears to the maternal genital tract when the baby is trying to come out, or injuries to the shoulder of the baby or the nerves of the baby, because the baby is so big, trying to come out from the birth canal. So all those manipulations of trying to pull a big baby out may cause bony injuries to the baby. The baby could fracture the bones, or a nerve injury around the neck to the baby. And we also know that when babies are postpartum, the babies run the risk of what? Sudden fetal death. Sudden fetal death. And we've already said that postpartum babies will have an increased risk of Caeserean section. So those are the problems with postpartum pregnancies. However, we do not have any of such problems with a post-date baby. That is a baby beyond 40 weeks. Because as I said, we do not like to wait for babies to get to postpartum before intervening. And that takes us to induction of labor. Generally speaking, induction of labor is carried out when you add 10 days to your due date. In Africa, in Nigeria, that is the gold standard. So that is 40 weeks plus 10 days, or 41 weeks plus 3 days. That is when we want to carry out our induction of labor in the absence of any problem to the mother or the baby. That is when we carry out the induction of labor. There may be indications or reasons why I may want to induce baby at 39 weeks, at 38 weeks, at 40 weeks. That is before the 41 weeks plus 3 days. But in the absence of any problem, we want to induce at 41 weeks and 3 days. But more commonly, we will tell the mother, please come in at 41 weeks plus 2 days, because before I induce you, I need to prepare your cervix. So induction of labor will be carried out, but it's always important to ensure the cervix of the woman is prepared and ready for the induction process. And that is what I call ripening of the cervix. If your cervix is not ripe, that induction process will likely fail. And that is why when you ask, but you told us that induction of labor is carried out at 41 weeks plus 3 days. Why are you telling me to come at 41 weeks plus 2 days? That is because it affords us the opportunity to ripen your cervix before we commence the induction process. And in trying to ripen your cervix, I tell my patients that, okay, we could pass a tablet into the vagina. That will help to soften the cervix and may also stimulate some contractions for us. But the main purpose of passing that tablet is to do what? To ripen the cervix, to soften the cervix. Because the cervix must be ripe, must be softened to a particular extent before you start your induction of labor. Also, there are some patients that maybe because they have delivered 3-4 babies before, we are afraid of passing that tablet to ripen that cervix because we do not want very strong uterine contraction so that it does not cause uterine rupture. What do we do in such situations? We can pass a catheter into the cervix and inflate it with a very good amount of water. So that will stretch the cervix and also stimulate some contractions. That is basically the two ways we have in Nigeria by which we prepare the cervix before induction. So induction is not just jump into induction of labor. The cervix must be prepared before you carry out your induction of labor. So the patient comes the night before, we prepare the cervix over the night till the next morning. So by the time the morning now comes, the patient, and we assess the cervix of the patient, they will now say, oh, madam, your cervix is ripe, your cervix is ready, we now are going to carry out the induction process. So by that time, the woman is now 41 weeks plus 3 days. And what do we do for the induction process? It can be either of 2 ways. We rupture the fetal membranes and the lipo, that is the baby's water, pours out. But once that happens, it stimulates more and more contractions for the woman. And we put up what is called a drip, and we add oxytocin into it. So that also helps to stimulate contractions. But it's imperative to know that the tablet we pass to ripen the cervix may also continue to cause contractions for us. So one needs to be careful in putting up oxytocin for the patients. So those are the 2 ways by which the induction process are done. And as I said, induction of labor is carried out at 41 weeks plus 3 days. But what may be the reason or reasons where your doctor, your gynae may say, madam, though you are 38 weeks, 39 weeks, I want to induce you. And you may want to ask why. So there are some reasons. It could be reasons from the mother or reasons with the baby. Some reasons in the mother whereby your doctor will say, madam, we need to induce you at 38 weeks, will be hypertension. Whether pre-eclampsia or eclampsia may be a reason why they may want to induce you very early. Sometimes the mother has drained fluid. Her water has broken, she's leaking fluid, and she's not having any uterine contractions. We call that pre-labor rupture of membrane. Because she has broken her water, we expect contractions to happen, but it is not happening. In such a situation, we will induce labor for such a woman. What if you come for a routine scan at 38 weeks and you realize that this baby's water looks too small for comfort? I know the baby needs water for its own existence. So at 38 weeks, I'm seeing that, or even at 37 plus, the mother, we notice via an ultrasound that the water is so small. Obviously, we will not be waiting for 41 weeks plus 3 days because that would be dangerous. We wouldn't want to hurt the baby. So in that situation, we will carefully induce such a woman while carefully monitoring the induction process, because when a woman has very reduced water and you are carrying out an induction process, we run the risk of fetal distress, because each time the womb contracts, because there is no fluid to serve as a buffer, the contraction of the womb may squeeze up the baby. And once that happens, that may lead to fetal distress. In such a situation, one may do what? One to carry out an immediate cesarean section because of fetal distress. There are some reasons where ab initio, a woman is totally contraindicated for induction of labor. From the get-go, we know that, madam, we cannot induce you for whatever reasons. Number one could be that if she has had a previous cesarean section, she will not undergo induction of labor. If she has had a previous fibroid surgery, obviously nobody will want to induce such a woman, because we all run the risk of tearing the womb and causing uterine rupture. So we don't want that to happen. So such women are not candidates for induction of labor. Or for whatever reason, there is a cord prolapse. The umbilical cord, after the water burst while she was at home, the umbilical cord jumps out before the baby. Obviously, that is a reason for immediate CS. So such a woman cannot undergo induction of labor. Or a situation whereby you have the placenta blocking the cervix, what we call placenta previa. Obviously, you know that we are not going to induce labor in a situation like placenta previa. Okay. And once the induction process starts, that is, you've ruptured that is the womb. When I'm talking about the induction process, I mean that the cervix is ripe already, and we have determined that the cervix is well prepared. Then we rupture her membranes and we put up the oxytocin. Okay. and we keep titrating this fluid that we put up until we get adequate uterine contractions, okay? And that could be called augmenting the labor process that has started. So whether, because some women will do tell me that, and doctor, this induction process I had is more painful than natural, than spontaneous labor. No, it is not. Totally not. Reason being this, what causes the pain? It's just like the menstrual pain. What causes menstrual pain? Is because the womb is squeezing, and trying to push out the menstrual effluent. So that's what's causing the pain. So that's why when a woman has heavy menses and is passing blood clots, and because the blood clot has to pass through the cervix, the womb has to squeeze a little bit more to push out this blood clot, there'll be increased pain for such a woman. So in labor, whether it was induction of labor or spontaneous labor, because we'll look at induction of labor as artificial labor, like, okay, it was the doctors or the nurses who stimulated labor for me, or whether you went into labor spontaneously, it all ends up in uterine contractions. It all ends up in uterine contractions. And it is the uterine contractions that is squeezing of your womb and the realization that is causing you the pain. So whether artificial or spontaneous is the same pain. So it is not increased or decreased. It is not more in induction of labor, neither is it less in spontaneous labor. The uterine contractions cause the pain. And obviously the oxytocin, that is that drip that is put up to try to stimulate more and more contractions, that also obviously causes the pain because of increased uterine contractions. So augmentation of labor basically is carried out when a woman has come into labor spontaneously. She's having contractions, but while in labor, we realize that the contractions are not adequate. Obviously, what do you do to augment? Simple, you put up your drip and put up your oxytocin. Same thing happens when you carry out your induction of labor protocol. Okay? And when we do induced labor, it could fail. And that may be a reason to go and carry out a Caeserean section. That could be failed induction of labor. And the number one reason that will most likely lead to a failed induction of labor is what? Not adequately preparing that cervix. It's like going for an exam, you have refused to read and prepare. Obviously, you are prepared to fail at the first instance. If that cervix is not adequately prepared, the risk of failing that induction process is very, very high. And that's why most doctors will want you to come in at 41 weeks plus 2 days, and they prepare the cervix over the night. Then the next morning, they will do what? Carry out the induction process. And that takes us to indications for Caesarean section. Obviously, from what we have been saying, a failed induction is an indication for Caesarean section. But there are many more reasons for why a woman will undergo Caesarean sections. It could be due to reasons of the mother or some things in the fetus and the womb. So some things in the mother that may make us decide not to go through induction could be hypertension also. But you say, yeah, but you already told us that when a woman is hypertensive, she can undergo induction of labor. Yes, I said so. But you're also saying that the woman can also undergo a CS straight away. Yes, I'm saying so. And the reason being that if a woman has a pregnancy-induced hypertension, and I'm seeing 140, 150 over 90, okay? And I said, okay, this blood pressure is high. Yes, I agree. But it's not very high as to cause sudden damage to the mother or the baby. Let us carry out this induction process at 38 weeks before the BP goes on to very elevated levels. However, this patient, even though you are planned her for induction, and she came on that day, and as she came, her blood pressure has shot to 180, 190 over 120, 150. She's not having headache. She's not having blurred vision. Obviously, it doesn't make any sense for any gynecologist to say, oh, but since I've told her induction, I must go on with the induction of labor. That is very dangerous. So hypertension in pregnancy may be a reason to go straight up to cesarean section, depending on how the elevation of that blood pressure is. Okay, other indications for CS would be a woman who has had a previous cesarean section. Usually run the risk of a repeat cesarean section, especially after 2 cesarean sections, because these more discussions obviously I've had over time about vaginal birth after a cesarean section. That is just 1 cesarean section, because if you have had 2, no story, no discussion, a repeat CS, that is a 3rd CS is what you will get. However, if you have had 1 cesarean section, you may have a vaginal delivery this time. So far, some criteria are met. And one of those criteria could be that your baby will not be more than 3.5 kg. If it's more than 3.5 CS, straight up. The baby must come with the head. If the baby is breech or transverse, CS, straight up. Also, you must fall into labor spontaneously. Nobody is going to induce you. You know, we already talked when we are talking about reasons for induction of labor. Sorry, when we're talking about contraindications. One of the reasons why I will not induce a woman, nobody will induce a woman who has had a previous cesarean section. It's dangerous. You don't want to do that. Okay? And these are some of the stringent criteria that many women will fail. And that's why when you have a CS now, just 1, the chances of having another CS is very high, but it is not absolute. What we know as absolute is a woman with 2 previous CS, that is absolute. Other indications for CS could be transverse slide. Okay, the baby is not head down, so indication for CS. Breech presentation. We'll do a cesarean section for such a woman. Or the person has cancer of the cervix, or a large fibroid, or multiple fibroids. Obviously, those are indications for cesarean section. That is because cesarean sections have become safe over the years because of good antibiotics, better skill sets, improved anesthetic techniques, blood transfusion services. Those have made cesarean section safe, and many people are opting for it. And may I also tell you that in the absence of medical indications for cesarean section, a lot of women are taking up social reasons for cesarean sections. That's because they want to keep their vagina intact. So they come and tell the doctor straight up that, oh, we want to have a cesarean section instead of a vaginal delivery. And obviously, we obviously will cancel them on the risks of cesarean section, and will obviously carry out a cesarean section for them. Other reasons for CS could be that, as I said initially, placenta previa. When the placenta is occupying the lower segment of the uterus. I see somebody ask, please keep your questions to the very end, though I've answered this particular question where somebody's asking that a woman has had 2 CS. Can she have a delivery? No, totally no. No discussion, nothing can be had. 2 CS, you must have another, you will have a 3rd CS, okay? And we'll keep other questions till when we are done. So as I was saying, some fetal reasons why we want to carry out a CS: when the baby is breech, a transverse slide, okay, placenta previa, when the placenta is occupying the lower uterine segment. Those are some of the, or rupture, abruptio placenta. No, a placenta is properly situated in your womb. It's not near the doorway. I mean the cervix now, when I call the doorway, because that is where the baby is going to pass out. But suddenly, for whatever reason, maybe because the mother is hypertensive and she never knew, the placenta tore off with bleeding. Obviously, that's an indication for cesarean section also. So these are some of the reasons. So we'll quickly go straight to the 6th discussion, that is postpartum blues. And postpartum blues, this is a topic that is not usually discussed often, but it's a very important topic because it deals with the mental health of our pregnant women and just newly delivered women. And it's very important because we all look at physical situations as the only problems affecting women, but the ones that physical problem is sorted out, like trying to breastfeed, they had a CS, they are healing well, everything is fine. But not everything is fine because mental health is becoming big issues around the world, and it could actually affect the whole being of the woman. Because the definition of health by WHO is not just the absence of diseases, but for the woman to be good in all areas, including social and mental. Would you please mute ourselves so that we do not disturb the class? Okay. Okay, so I think that is done. Yeah, so I was saying that mental is a very big issue, and that's why postpartum blues, you will look at it as a postpartum mood disorder. But you could call it a mental disorder, but we'll just call it a mood disorder so that we won't scare people with that big word of mental disorder. That people won't think, am I crazy? No, you're not crazy. We'll call it a mood disorder. And mood disorders for the woman who have just delivered can be postpartum blues, can be postpartum depression, or postpartum psychosis. So we will not talk about psychosis today, maybe another time, okay? Because that is a situation of being frankly mentally, with a frank mental issue, okay? We'll just stick with mental postpartum blues and postpartum depression. Postpartum blues, this happens to up to 85% of women. And obviously, you'll not be asking 85%, that is like out of 10 women, 8.5 women postpartum blues will happen to. So for you who have delivered before, you are not thinking, may it have happened to me? So following this discussion, you obviously take notes and see if that's happened before, what you can do to prevent a recurrence. And if you have a friend who has delivered, how do you quickly identify a woman who is having postpartum blues? And how do you help such a woman in your church, in your community, at your place of work, when you go visiting? Okay, as I've said, it happens to 85% of married women, while postpartum depression happens to just 10 to 15%. So it means that majority of those mood disorders happen to women, 85% of those mood disorders are postpartum blues. And by the 4th day after a woman has delivered, whether by cesarean section or by vaginal delivery, you start to see those symptoms of postpartum blues. But the beautiful thing is that postpartum blues is self-limiting. By the end of 2 weeks, we should not see postpartum blues. If it persists beyond 2 weeks, then we should be watching out for postpartum depression in such a woman. So within 4 days, it starts and it resolves by 2 weeks. And what are some of these symptoms that you should take note of in women with postpartum blues? The woman will be looking unduly sad. She'll be teary. You ask her, Mama Nkechi, so why are you crying? Apparently, she doesn't know. She'll have a feeling of not being good enough to care for the baby. She'll just be irritable. Into our African culture, just, madam, you just delivered, you should be happy you are seeing your baby. But the woman is passing through so many issues as at that time. So if not quickly identified, it could progress to postpartum depression, which would have long-term implications for both herself, her husband, the child, and even the children she does have at home. However, women with postpartum blues, as against women with postpartum depression, is that women with blues are still able, despite the fact that they are teary, they are irritable, they are still able to do what? To self-care for themselves and care for the baby. So there is no fear for the baby as against women with postpartum depression. So we'll talk about that when we get to postpartum depression. So they're still able to care for themselves. They're able to feed the baby, bath the baby, do some things for the baby, okay? And as I said, it's a self-limiting problem. But what are some of the reasons why women, up to that 80 to 85% percentage, have postpartum blues? So what are some of the risk factors for postpartum blues? Majority of the risk factors are psychosocial. And some of them could be marital disharmony. If the woman is unhappy at home, she's fighting with her husband or fighting with her relatives, maybe most likely her mother-in-law, it could potentiate or it could rear up postpartum blues. And if not properly managed, you can move on to postpartum depression. Financial difficulties, loss of job. These are some of the reasons why a woman may have postpartum blues. Lack of social support. Yes, they are financially okay, but the man is not, or her partner is not emotionally available for her or physically available for her. So she feels she's in this business of pregnancy and this business of caring for the child alone. That could stir up resentment and could lead to postpartum blues. Other reasons could be historical reasons. If the woman has had a previous history of postpartum mood disorders in the first or second pregnancy before, you must watch out for it in this pregnancy or after she delivers. So such information is very important for us as caregivers, asking that, madam, any mood problems, any mood issues when you deliver the last child? Okay, and you see a very quick way to catch a woman, because she comes to your office, she comes to see you, or you just go visiting and she just begins to cry unduly. And she's unable to really put a finger on what is making her cry. That may be postpartum blues. It's not readily diagnosed in Africa. That is because we just tell the woman, madam, be strong. That is it, be strong. Okay, why not addressing, taking time to speak with her, taking time to look at the psychosocial issues around her and trying to address it. People with family history of mental disorders, family history of depression, they run a risk of having postpartum depression. If the woman had had a history of depression before, she has a risk of postpartum depression. Where I said postpartum blues, let's not miss it, is a self-limiting problem. We expect it to resolve in 2 weeks, and it will resolve faster if what? The woman is given the necessary emotional support, meaning that you identify with which area is the problem: marital disharmony, lack of emotional, lack of physical support. Okay, identify with this, talk to her, converse with her, hear her side of the story, okay, and reassure her. So that would usually be sufficient to help a woman with postpartum blues, so it doesn't go to postpartum depression. And the risk factors for postpartum depression is not different from the risk factors for postpartum blues. So same psychosocial risk factors, same history would also, or previous depression would put this woman into postpartum depression. But what will differentiate a woman that has postpartum depression from just simple postpartum blues? As we said earlier, 10 to 15% of women who have just delivered would have postpartum depression. And it begins gradually within the first 3 to 4 months of delivery, and will last up to 1 to 2 years. Will last up to, I've seen a patient like that, up to 1 to 2 years, which we are still managing for. So it's not something that does not happen. It does happen. 10 to 15% of women who have just delivered will have postpartum depression. And for such women, they will have severe sadness. They'll just go into their shell, maybe staring at the wall, severe sadness, feeling very depressed. And they will have what we call anhedonia. I will explain that. A situation whereby normal pleasurable activities like going out, seeing their baby, wearing a new clothes, doing a new hair for the woman, normal pleasurable activities no more becomes pleasurable for such a woman. When that happens, then you know that this is a big issue. And the major difference between depression and postpartum blues is that the woman is unable to self-care for herself. She's just being in the room. Mama, Nkechi, why are you not going to take a bath? Why not go to the club? She's not bothered because there's no pleasure for her anymore. And she won't be able to care for the baby also. Leave the baby unattended to. And that is a very dangerous situation. More also, for them, they may start to have suicidal thoughts or thoughts of harming the baby. So you can see that if one does not recognize all these telltale signs that we are talking about this morning, then we run the risk of that mother injuring or killing the baby, which has happened before. So one should do well not to just dismiss it as, oh, she just delivered, you get out of it. I gave birth to 7 children. Well, I was strong. Not everybody is mentally strong as other people. So each patient or each person needs to be taken individually in its own merit. And once you see a patient having such, please do send the patient to see a gynae who will further discuss with the patient and obviously hand over the patient to the mental health physician. Seeing the mental health physician, obviously they will organize a behavioral therapy for her to try to keep talking to her. It could be a support group because she's not the only one, obviously, that has postpartum depression. There could be a support system, a support group whereby women are able to share their experiences. And by the time you realize that you are not the only one with these experiences, it helps your healing process, okay? Because in life, when you presume that you are the only one with the problem, then it becomes a weighty issue for you. But if you are able to see like minds, you are able to share ideas, share healing processes, then that also helps your own healing process. And also drugs may be used to lighten up the mood. So the mental health physician will prescribe such medications. And some of these medications are safe to be taken while the mother is breastfeeding. That is the fear. But the most important thing is to recognize that this woman may have postpartum depression. Let her go in and see the doctor. We'll call a stop here and we'll entertain questions. Okay, so please, you have the opportunity of unmuting yourself if you want to ask questions. Okay. Please, we'll take questions now. Some people send some charts. Let me see what is going here. How do we prepare the breast for breastfeeding? Please, I have no clue. That it was not our discussion today. I didn't think we talked about the breast today, but as I always say, we could ask any question and we'll do well enough to answer the question. I think Matron, Ms. Addition, are you around?
Around.
You're beautiful.
Yes, I'm around.
Beautiful. A woman, so I think I would, a woman asked the question that how do you, yes.
Prepare the breast.
Prepare the breast for breastfeeding.
For lactation.
So maybe that, yes.
Yes. When you notice that you are pregnant, the first thing you see in your breast is that you see your breast gets enlarged. And sometimes some liquid starts coming out. If you don't clean it, they get dried and form crusts on your nipples. They can even occlude the holes in your nipple. So what we tell you to do is, before you sleep, you can rub Vaseline on your nipple and areola. The following morning, when you are having your bath, you wash it, or you put soap on the palm of your hand, the two hands, and rub it and wash the Vaseline off it. But at that time, the liquid that has become dried and caked and covered the holes in your nipple would have softened, and then washing it with soap will clean it. You can do that twice in a month before you deliver. And by the time you are going to deliver your baby, you will be sure that your nipple will be clean and there won't be black crust on it.
Thank you, Matron.
You're welcome.
Beautifully answered. Thank you so much. Okay, somebody also sent in a chat. What are your thoughts on carrying out a fibroid excision alongside a cesarean section? What are the pros and cons? Please take it as the gospel truth that fibroid surgery at cesarean section should not be done. That is your baseline information. Okay? Fibroid surgery during cesarean section should not be done. Okay? That is because you run the risk of having severe bleeding on table, which could lead to several blood transfusions or even death. That is because fibroid surgery on its own, without a woman being pregnant, leads to a lot of blood loss. Not to talk of a very huge womb that is also pregnant. So you run the risk of hemorrhage. However, there are some exceptions. I will not be discussing such exceptions here, so that will be taken as on a case-by-case study. Okay, so if you do have fibroids, okay, your gynecologist will assess you primarily, okay, and he will make such decisions. But please take it, no fibroid surgery should be done at cesarean section because there will be risk of severe bleeding. However, exceptions can be made. That will be at the level of your gynae and you. Okay. So any other questions, please?
Yes, doctor. Okay, doctor, can you hear me?
Yeah, I'm with you.
Yeah, you say something like 10 days to your due date, that is when induction is carried out. Now, what I don't understand is it 10 days before or 10 days after?
Okay, thank you, ma. I did not say 10 days to your due date. I said 40 weeks is your due date, right? And we all know 40 weeks of due date. So 10 days after that is when we do induction. That is 40 weeks plus 10 days, or 41 weeks plus 3 days. That is when we carry out the induction process.
Okay, 10 days after. All right.
After, beautiful, after. Okay, so there's another question here. Doctor, what is the likely factor bringing about increased occurrence of CS in modern day compared to, I think she was asking that in the days of our fathers, the cesarean section rate was lower compared to now. Well, I'll give you this. WHO, that is the World Health Organization, tells us that we should carry, as in the percentage of cesarean section carried out should be 15% from World Health Organization. But we've seen that the prevalence of cesarean section is a little bit more in some certain areas. And that is, apart from medical reasons for CS, a lot of people are now taking up social reasons for cesarean section because they want to obviously keep their vagina intact. They do not want the baby's head to overstretch the vagina. Okay, so that may also increase the risk of cesarean section. Also, we should not forget litigation. Patients are now getting more aware. They are knowledgeable. They have read even before coming to see the gynae. Okay, so by the time they are seeing one or two issues where the doctor is saying, well, I think I may be able to manage it vaginally. I say, no, doctor, I've read about this. I think it's safer for me to go for a cesarean section. Obviously, that starts to push the rate up because of the fear of litigation, because labor, the gynae will never rest until the woman has delivered and the baby is fine, the mother is fine. Okay? So, and sometimes our guys, we always say that labor is a 50-50 business. Okay? And CSs in quotes, have become safer over the years because of skill sets. Okay, so litigation and social reasons have driven up the rate of cesarean section. Okay, any other questions? Okay, I think there is one more. Okay. Okay, I am 38 weeks now, and my face, legs are always swollen. Also, I feel some slight pain on my legs. Should I be concerned? Okay, you are 38 weeks, and we've already agreed and said that 37 weeks is time for us. Okay, means that at 38 weeks, still early term, but your baby is term. Your legs are swollen. Leg swelling in pregnancy, as I always tell my patients, is not out of place. The most important thing is to ensure that your blood pressure is fine and your urinalysis is free of protein in your urine. If those two are fine, then I have no problem with leg swelling in pregnancy. That is because your womb is in the way of the flow of blood and fluids from the lower part of your body, that is your legs, up to your heart. So that womb is in the way. It's like somebody standing on a hose and trying to wash. Somebody standing on a hose and trying to wash his car. Obviously, when you stand on it, you are going to block flow of water. So that also happens with leg swelling. For you, madam, please, let's know, go into the hospital, ask for your blood pressure, ask about your urine analysis. If they are fine, then I have no problem with your leg swelling. Another question, doctor, please, if a woman has a CS once for delivery and just one side was a bit opened and later switched, can she later have 4 years? This question, can she later, after 4 years, deliver through vagina? Well, I think I addressed this issue while we were having that indications for cesarean section. I've said that if a woman has one cesarean section before, the risk of having another cesarean section is high. However, she can have a vaginal delivery, so far some criteria are met. And I've mentioned those criteria. Your baby must not be more than 3.5 kg. Your baby must not be breached, must come with the head down. Also, we've talked about the weight. Also, you must fall into labor spontaneously. Nobody will induce a woman who has had a previous cesarean section. So those are some of those reasons, okay, why you may want to have another CS after a previous cesarean section. Vaginal delivery is possible. It has happened severally, obviously, if a woman has had a CS before, but those criteria must be met. So mean that you must discuss this with your doctor very clearly. Okay. So any other questions?
Actually, mine is not a question, it's just a concern. I noticed that yesterday my level was just paining me.
How many weeks are you?
I'm 34, 4 days.
34 or 24?
34.
Okay, 34. You have some
Yes.
abdominal pain. Well, if you do have abdominal, and you said it's around the navel, it will be important. And has it still persisted, or it has gone?
Morning. No, even this morning, even as I'm talking, it's still there.
Oh, you are still feeling it. Well, we do not like abdominal pain in pregnancy, okay? Especially since you said it's around your navel. If the abdominal pain was around your pelvis, let me stand up a bit. If your abdominal pain was around this area and not here, this is your navel, if the abdominal pain was around your pelvis here, then I could say that maybe that is your round ligament that is supporting you that pain. But now they are saying you're having pain around the navel region, I will advise you to go in straight to the hospital, carefully be examined by the doctor. And another question will be that in your early scans, was there any fibroid found?
No, sir.
No. Okay.
Yes,
so I will implore you, if you're having pain around the navel region, please go into the hospital. Let a doctor assess you. Okay. He needs to make an assessment of that pain. Very important.
Okay, thank you.
You're welcome. Any other question? I think we have exhausted our questions. Okay. In the absence of questions, we want to appreciate everyone for once again joining this Zoom meeting. And you can follow.
Thank you, Doctor.
You can follow the previous. You're welcome, Matron. You can follow the previous classes. I think there's a link for previous classes. Okay, you can also join us. Okay, so thank you, everyone. God bless you.
Amen. Bye.
Bye.
Thank you, sir. Bye-bye, sir.
Thank you.
Thank you.
You're welcome.
Thank you,
Doctor.
Doctor.
Thank